Hello and welcome back to my channel. We just went over right heart cath and we touched about left heart caths a little bit, but now we're going to dive a little deeper. So if you've not seen that right heart cath video first, go ahead and go watch that. But if you have and you're ready to dive into the next step, let's go. So what is a left heart cath? So a left heart catheterization. Remember, a patient might have a right and a left heart cath, just a left heart cath, or just a right heart cath. Just a left heart cath is definitely the most common that you're probably going to see a patient go for, and let's talk into the reason why. So during a left heart cath, they're going to have an arterial access. So the left side of the heart is oxygenated blood. Those are your arteries. So it goes up to the way in which we are going is actually retrograde, the opposite of blood flow. So we go through the aorta, through the aortic valve, and into the left ventricle. We can look at the coronary arteries and we'll talk about that in a minute. But the access to get there, remember, everything is connected. So if I access your femoral artery in the groin, I can go all the way up to your heart, the radial artery or the ulnar artery. Now with the radial artery, we actually have some new accesses. So proximal is the original one. It's on the inner aspect of the wrist. So if you flip your hand over, palm side up, over on the side towards your thumb, in your wrist is your radial artery. That is what we would call proximal access. Now, if you flip your hand back over, on the top aspect of your hand, that is distal access. Okay, it's kind of going to be between your thumb and your first finger in that little divot. That would be distal radial access, but it's still going into the radial artery up to the heart. Then you have ulnar access. So again, flip your hand back over, palm side up. If you have your thumb and your fingers, ulnar is over here by the pinky, radial is over here by the thumb. So over here by the pinky, the small finger, is going to be your ulnar artery. We could use any of those. The femoral artery we'll use for more complex procedures where we need to use support devices like Impella, or even if your patient needs a temporary pacemaker femorally, we might choose to use the femoral artery for the rest of our procedures since we're there. But a lot of your diagnostic procedures, if we're not fixing something, will go radial if the patient's body habitus allows us. Some people have very, very spasmic radial arteries. Some people have peripheral disease and occluded radial arteries, so that's not an option. But you can definitely also have peripheral disease and have occluded femorals as well, leaving radial or ulnar as our only option. Now, what can we kind of get and look at while we're there? Well, first of all, left heart pressures, you have to know where you are. We're in the arterial side, remember we said that. So you could transduce the pressure anywhere you are in the body. So I could transduce the femoral artery pressure if I wanted to, just hook my manifold up to the transducer and start to get that femoral artery pressure. If I'm in the left ventricle, I definitely want to obtain left ventricular pressure because we can look at the LVEDP, the left ventricular end diastolic pressure. That'll tell us how the function of the left side of the heart is doing, specifically the left ventricle. If there's an increased workload, we'll start to see that LVEDP elevate. If there's some volume retention related to left-sided heart failure and those types of things. We can also get aortic pressure. If you've heard of like coarctation of the aorta, where you have the aorta and you actually have a stenosis right here, that is congenital in nature. So when we transduce a pressure, there's going to be a pressure gradient there. Same with the femoral artery. You could pick up peripheral disease by the difference between your aortic pressure and your femoral artery pressure. We could evaluate the aortic valve, right? Aortic valve area by checking for a gradient between the left ventricle and the aorta, because between the two of those is the aortic valve. So if your patient is going for a TAVR, transcatheter aortic valve repair or replacement, or even a surgical valve, they're going to have this first to evaluate that aortic valve area invasively versus just estimating off of an echo. And sorry, left atrium, nothing for you. So the way that we really go into the body, remember I said, is retrograde, meaning against normal blood flow. So if you have, let's say this is the femoral artery in the groin, for instance, I'm coming this way. This is the aorta. And I am crossing through the aortic valve, which is right here, into the left ventricle. Okay, the left atrium is, well, in this specific view, this is RAO, it's over here. It's very hard for me to go through the mitral valve and get up there. I definitely think you could if you really, really tried, but that's not really recommended. So instead, we estimate left atrial pressure. Remember, we can get pulmonary wedge pressure if we're doing a right heart cath, and that should estimate left atrial pressure. We're really only going to do that if you have a question with a valve that would be directly affecting that pressure, which is the mitral valve. So if your patient has mitral valve regurg or mitral valve stenosis, then we're probably also going to do a left and a right heart cath to be able to get that pulmonary wedge pressure from the right heart cath side to evaluate that mitral valve appropriately. But in everyday normal heart cath, left heart cath, we're just going to do these 2 pressures and call it a day. So remember, pressures we can get are AO and LV, or yes, you could transduce pressures near access. We can get saturations, so the percentage of oxygen in that blood, just like we did for the right heart cath. We can get an AO saturation, which is actually necessary if you're doing a left and a right heart cath to calculate FIC. Okay, FIC, cardiac output, that uses both a PA sat, pulmonary artery sat, and an AO sat to calculate. That's not the formula. I was just trying to write it out. Here you go. PA and AO to calculate cardiac output. We can do coronary angiography. That is one of the #1 reasons for getting a left heart cath is there's something wrong, or we perceive that there's something wrong with their coronary arteries, some type of ischemic disease. A left ventriculogram, this is not always performed anymore, but it definitely can be, and it gives us a lot of information, especially for Takotsubo patients. So if you've heard of broken heart syndrome before, where you have a really, really low cardiac output, you start to get this disconnect in the way that your left ventricle is contracting, which is why you're getting that low cardiac output, usually stress-induced, catecholamine-induced. We can take an LV-gram to assess for that. And then what you're checking for is, like I just said, the cardiac output by estimating what the ejection fraction is. How much of that volume of contrast that you injected into the left ventricle is ejecting out into the aorta. That gives you a good idea of how that left-sided function is doing. And you could correlate something weird with the LV-gram that you found in their echo, and you could correlate that to if their LV-EDP is increased. And then when you look at the coronary angiography and you say, oh yeah, they have disease in their LAD, and I saw that the anterior wall was moving really slowly. That also came up on the echo, and I see the LV-EDP is 20, which is elevated. Then you could attribute all of those things to the coronary disease that you found in the LAD, and you could say, okay, we're proceeding to fix this because I think that's the reason for their symptoms, as well as the findings that we found on both the non-invasive and the rest of the invasive testing. So that's kind of how everything rolls together. So when would a patient have a left heart cath? Obviously, you don't have all of that information before they have any tests done. So you're going to do it when you either suspect that they have coronary artery disease, or I could also say valvular disease, which we'll go over, or if you know they have coronary artery disease. So there's a lot of patients who have a history, either a history themselves or a family history. They might not always be symptomatic, but let's say one time they were found to have very severe disease but didn't have the typical symptoms that you would expect, right? Chest pain, those types of things. They were just a little fatigued. Well, if I know that they've had coronary disease in the past, they had severe disease, and they say they're feeling fatigued again, that might not be a classic sign for coronary disease, but they might get an indication for a left heart cath anyway. If they had a positive stress test to even correlate that a little further and say, you know what, let's take a look at this. Because remember, there is risk. This is an invasive procedure, so you do need to have some type of non-invasive indications or symptoms saying that this outweighs the risk of getting this invasive procedure done. So you could have symptoms or a history of myocardial infarction, so that's a heart attack based on a coronary blockage, valvular disease, intracardiac shunts. So some of these structural issues, remember, we're looking at the left ventricle, we're getting saturations. You might need the right and left heart cath both to fully evaluate these valve functions and areas. A congenital heart defect. So some patients have a VSD, a ventricular septal defect. So if this is the right ventricle and this is the left ventricle, let's say, some people have a little hole in their heart. So you have this shunting and mixing of blood. You could have it in the atrium as well. And between the two atrium, you could have a little hole and shunting of blood either way. Same idea. A cardiomyopathy. So if we break this down, this is a disease of myocardium or myocytes, and that is a cardiac related issue. So disease of the myocardium in the heart, and that is going to be indicated by, remember the LV-gram we talked about, Takotsubo is a form of cardiomyopathy, or we can have thickened myocardium, hypertrophy, you can have dilation, and we could evaluate all of that, not just with pressures, but visually with that contrast as well. But a lot of the reasons for these issues, like cardiomyopathy, is cardiac is coronary artery related. So you could have an ischemic related cardiomyopathy. And the reason you're going to find that is you find coronary artery disease directly related to the area in which the cardiomyopathy is occurring in the left ventricle. Same with valvular disease. There are actually certain ischemic conditions in certain coronary arteries that can cause a valvular issue. So for instance, circumflex related disease could cause mitral regurg. You can have ischemic related mitral regurg. So that's important to look at as well. Some other things, elevated troponins. So the troponins are what we pull in STEMI patients. Someone comes in with crushing chest pain, we're going to pull serial troponins, so a few of them that are going to trend over time. So they're going to peak at first because you're having an ischemic event, and then as that myocardium heals, that troponin will kind of trend down. So you can look for this when we're looking for coronary disease. Remember, it could be an emergency. So STEMI cardiac arrest patients, you might not have any of the, like an echo or a stress test, any of that non-invasive testing first. They might strictly go to the invasive because they're having an active event. That would be shown, right, with ST elevation on the EKG. Unexplained. So someone could have an unexplained chest pain. They could have ongoing chest pain, all of their tests are negative, but they continue to have this chest pain. We might perform an invasive procedure to be able to see, is there something that we are missing? We've done all of the tests, nothing came up, but they're still very symptomatic. You can't just ignore that. Now, relative contraindications. When would, in certain situations, a left heart cath be avoided? And I say this because this can kind of be subjective. Remember that patient I talked about, if you have had an event in the past, but you don't fit the normal category of everybody else, that doesn't just mean that you get ignored, right? Some of those patients will opt for some type of invasive test to rule out anything serious going on. So I say all of this too because some of these are going to be reasons for the patient needing to have this done, and we'll talk about this in a second. So renal failure. The reason for this is we give contrast. Contrast is an agent that we use to inject into the coronary arteries to visually see things on fluoroscopy. Okay, we're in black and white imaging here. Contrast is radiopaque. It will show up, and if the contrast is moving, that means that the blood is moving in that area. Now, contrast is filtered through the kidneys. So if someone has kidney disease, that can be an issue. Some physicians like to hydrate their patients before, either because they do have renal disease or just as a preventative. And there is a hydration protocol after as well to make sure that that filters through. But if someone has end-stage renal disease, they're not on dialysis yet, they might not want to take the risk of giving them additional contrast that would push them over that edge if they're not 100% this procedure is going to benefit them. And electrolyte imbalance. So let's talk about potassium and magnesium. So potassium and magnesium are directly related to some, I was going to write torsades here with magnesium, are related to some arrhythmias, so abnormal rhythms in the heart. When we are poking around in the heart, we're injecting things in the coronary arteries that feed blood to the myocardium. When we are physically putting a catheter in the left ventricle, and there's some of the conduction system over here, we can cause arrhythmias. That's kind of part of the procedure sometimes, and we know if we put a catheter in the ventricle, it's very likely to see a PVC or two on the EKG. That's not abnormal. We're tickling the ventricle. But if they have an electrolyte imbalance, very, very low potassium or high potassium, low magnesium or high magnesium, they're predisposed to getting these arrhythmias easier and sustained for longer. So we might want to fix this first before proceeding with the heart cath. It doesn't mean they can't have one ever. It just means you really need to address this first before proceeding with this. Same with this. If they have new type of renal failure, their creatinine's high and hasn't been ever before, maybe it's medication induced. So maybe we'll DC that medication before them proceeding with the left heart cath if they really need it. Uncontrolled arrhythmias like VTAC, same kind of thing here is, right, we could cause a PVC or something and we don't want it then induce an arrhythmia, so this needs to be investigated first. Uncontrolled hypertension. So this one's a little difficult for people to understand. Yes, we're giving fluids and contrast and all of those things, but we are also, so if I draw a coronary artery here and our catheter is here, okay, so, and this is in your aorta. So we are injecting contrast into the coronary, right? But my equipment is engaging into this artery as well. So some people, if you have hypertension, your arteries can be predisposed to what we call dissection. So under intense pressure or from a mechanical aspect, right, catheter engagement, for instance, going up against the vessel, I'm injecting contrast against it. I want your arteries to be happy and compliant with what I am doing in and around them. So hypertension causes unnecessary stress in that area where I'm going to be causing stress trying to do the procedure, or a physician will. So we really want to control this first, either with medication, etc. Sometimes sedation will also naturally decrease the blood pressure. My dog is squeaking. So we want to control this first, again, before proceeding with the procedure. Now, for crossing the aortic valve into the left ventricle, this is something I bring up because it's not really related to the coronary artery engagement themselves. A right bundle branch block. So we talked about this with the right heart cath, but we said left bundle branch block was the issue. So if they have an underlying or existing right bundle branch block and we are crossing into the left ventricle, let's see if you can remember some of this before. And our conduction system was running in the interventricular septum, right? So you had the right bundle branch and the left bundle branch. Well, if they have an underlying already right bundle branch block, we put a catheter in the left ventricle, and let's say I knock out this bundle branch, transient or not, I knock it out, they end up with complete heart block. So that's something important to bring up to the physician if the patient has a history of that or presented with that, so that they know. And again, if we are doing some sort of procedure that involves us being in the left ventricle for a while, might put in a temporary pacemaker to be able to proceed. Left ventricular thrombus. So this one's important because you won't always have this information. You would see this usually if they had an echo first, because that will show you a visual image of the left ventricle. Usually in the conclusion, it'll be noted if there was found to be left ventricular thrombus and if it is mobile. Okay, so mobile means it's not fully attached to the wall. And remember, we're sticking catheter in the left ventricle, and we don't want to then mobilize that thrombus and it come out the aorta and result in a stroke. So that is a really good reason to not do the heart cath, or to, if you really need to do the coronary artery angiography, you might not cross into the left ventricle at all, just to avoid that completely. Mechanical aortic valves. So mechanical aortic valves are made of different types of metal. And again, we could proceed with the coronary angiogram, but we just wouldn't cross into the left ventricle to leave that valve alone. We don't want our wire getting snapped off or our catheters being damaged, and we definitely don't want to damage the valve. So that's important to know about your patient beforehand as well. Or when you step on the first fluoro image, you can see it on fluoroscopy, even if you didn't know if it was in their history. Now, what are some of the complications that can happen during this procedure? And again, I don't mean to scare anyone, but if you are working in the cath lab, you really need to know every worst case scenario that could possibly happen, because a lot of these things are preventable if you pick it up early. If you're like, oh, I know what that's leading to, or I know what that is, and you can intervene really early and prevent it from becoming an event that's difficult to come back from. So first off is access. Access is very important. There's a reason that a lot of physicians are starting to learn how to do radial if they don't know already. There are their own complications with radial and ulnar access, but there's also a higher bleeding risk with femoral access. It's a larger area. It also is right below the retroperitoneum, the abdominal cavity, where if you have a bleed, it can be very sneaky because that's a very large area to bleed into without you really knowing right away. So that is what we would call a retroperitoneal bleed. That is from an invasive procedure, okay, not some type of other external trauma-related thing. Let's draw here. So let's say this is the femoral artery that we are trying to access. We have below here, it bifurcates into what we call the SFA, the superficial femoral artery, and the profunda. The profunda has a lot more branching. I know, I'm not a great drawer when I'm just sketching. Very different from my nice drawings. And let's say this is your target. This is the femoral artery where you want to access. Now there's a small little branch up here that is the bane of everybody's existence called the inferior epigastric. And that feeds into this area, the retroperitoneum. So if we stick too high, we have a high stick, you could nick this and that could cause a retroperitoneal bleed. It won't be immediate, right, unless you perforate or something, but it could be a very, very slow leak, slow bleed. hypotension over time, hypotension in post, new onset back pain. Those are all good indications. Definitely there is a resolution for that, right? You have vascular surgeons for a reason. Or if you took an Acist image and you saw that there was a little bit of a bleed, you can call attention to it before it's an issue. But it is something that you can avoid by using, ultrasound, taking an angiogram image, seeing where you are in relation to the epigastric, in relation to the bifurcation. And if it is too high, that's why you see people using micropunctures, so that you can pull that needle and that small catheter out or small sheath at that time out and hold hemostasis and try an alternative access. So definitely avoidable, just something to pay attention to if your physician does go femoral a lot. Start to learn what ultrasound images look like, really get familiar with peripheral anatomy and what the femoral angiogram looks like, so that you can identify how good or poor that access site is. Arm or leg ischemia. So arm would be from ulnar or radial access, and leg ischemia again would be from femoral access. Now this comes from usually, not always, but usually thrombus. So this has to do with post-procedure, when you're done, how you handle the sheath. If you fully aspirate a syringe, put it on a gauze, and then you can see the little bit of thrombus that was in there, because that sheath has been sitting there for a while, especially if it was a diagnostic and you're not anticoagulated. It's not a surprise, but what you want to do is make sure you're getting clear syringes before you take a new syringe and you inject it into the sheath to clear out the sheath. Because if you do it with the thrombus in there, then what you're doing when you inject the sheath is that thrombus comes out and then can get stuck in that artery and close off blood flow to the hand or leg, which we don't want. So there are, again, preventative and proper ways of doing that, but make sure you learn sheath management really well if you are scrubbed in. Vasovagal response. So also this can happen in post. Usually it has to do with the arm and the pressure band, the hemostasis band or bracelet that the patient has on. If it's left on for too long or there's too much pressure in there and you can physically see that the patient's hand is discolored, you only want to put what we call patent hemostasis. As much air in the balloon as you need to not bleed, but not so much that you cut off blood flow. Vasovagal. So this is usually during the sheath pull. So if you're pulling a femoral sheath, for instance, and you hold way too much pressure at first and the patient has a lot of baroreceptors there, they can start to get hypotensive and bradycardic. That's a very good sign of vasovagal. There are resolutions for that as well, but it's something you want to pay attention to if you're pulling a sheath for the first time. I always like to have somebody else there with me, even if I'm very comfortable, because if something like this happens, you can't do anything, right? You're holding pressure in the groin. If they need medications, you have to continue to hold hemostasis. They're going to bleed. So it's very, very good to have a second person in the room watching you, just in case. Now the rest. The other things that can happen, again, very, very small percentage, but stroke or cerebrovascular accident, like we talked about before, like the LV embolus, rare, but embolization of air or bacteria, I mean, you're not going to go through an infection. Embolization of thrombus from like the sheath or the catheter if it's not being prepped correctly, or from the wire if it wasn't wiped, could cause stroke or CVA. Myocardial infarction, so that could be from our catheter engagement. We could dissect embolus, again, from injection of thrombus from the guide catheter or from the manifold. Aortic dissection from the wire manipulations in and out, which is why you don't push against resistance. If you feel resistance, say it. We can fluoro and see what we're looking at. We can take a little angiogram, see what we're looking at. Tamponade, cardiac tamponade from a perforation, that's usually during intervention. Arrhythmias, again, arrhythmias are not super surprising because remember, we're messing in the coronary arteries in the left ventricle, but we don't want our sustained arrhythmias. So if you have PVCs, just call attention to it. But if you have a sustained, you want to prevent something before you end up having a sustained rhythm. So remember, both diagnostic and interventions have complications to look out for. Interventions can definitely increase those complications because we are not just within the coronary arteries, but we're also anticoagulated. So thinner blood means you bleed faster if you do have an issue. So we want to be very, very careful there. Now, what type of equipment are we using? Well, first and foremost are the catheters. The catheters are kind of our arm into the body, right? You have all kinds. It depends on the patient's anatomy, what coronary you're looking at, what access you're at. We need different curves to get different places. We can manipulate this in different ways, but if it's just not working, don't worry, because we have hundreds of alternative options. Wires. So the 035 wire is the most common. We use the 035 wires for these catheters. Okay, this is relatively big in comparison to the other types of equipment we use. And an 035 wire is what this catheter will go over. It usually has a J tip, so a J wire, because it has that atraumatic curve at the end. So as we're moving this catheter in and out of the body, if you see on the catheter, it's a blunt tip. So that wire at the end helps this track over this, and the end, if it's up against the wall, will naturally curve away versus digging into the wall, which is where you get dissection. So we want that atraumatic tip. That's why the J wire is the most common that we use. If the J wire isn't working, usually to track through tortuous anatomy in the radial artery or up in the subclavian, we can try different things. So you can have glide wires that are slippery when wet. They're also usually black or blue. They have a these right here. They have a hydrophilic coating on them. Hydrophilic as in, quote, liking water. So when you get it wet, it's very slippery. It's very easy to track through tortuosity. The Amplatz wires are blue. Most of them are blue. They are very, very stiff and give improved support. So you're not going to be using them for the whole case, but you could use it to track through, for instance, femoral artery disease. If you're having a really hard time delivering the sheath, you could use that to kind of straighten out the vessel and support the equipment insertion. Straight wires. Now, instead of the J tip like this, it would have a straight tip. Now, obviously there are issues with that. It serves a very specific purpose to cross through a stenotic aortic valve, and then once you're through that valve, you're going to exchange out that straight wire for a J wire, because when we're in the left ventricle, right, we don't want a straight wire in there to poke through. Instead, you want a nice J wire so that it curves up against the apex. 014 wires. Now in diagnostics, we don't use 014 wires a lot. There are specific scenarios. The 014 wires are smaller than the 035 wires, so they're used for interventions. These 035 wires are too big to go in a coronary artery without causing issues. So instead, to track through the coronary artery, you're going to use the smaller 014 wires. And again, we do shape the tip. They start straight, but we shape it into different curves, but usually some form of J to be able to be atraumatic and cross through. Now, for diagnostic purposes, the 014 wires can be used to navigate tortuosity, usually in the arm. So the radial or ulnar arteries are very small. If the 035 wire isn't tracking or it's causing vasospasm because it's too irritable, we can use the 014 wires to track through and try to find the vessel that we're trying to go through. And then same idea with the straight wire. When we get to a comfortable place, we can exchange out for the 035. How are we able to transduce pressure and inject contrast to see? So for a first-time cath labber, it's kind of remarkable what we're able to do from completely outside of the body, just through this tiny hole and these tiny little pieces of equipment. So what we use are one of two different things. Some places use a manifold and some places use an Acist, but they serve relatively the same purpose. So the old school way, the way I was trained on and I really like, is the manifold. So this is a manual injection. The rate and the volume is controlled by how much you push. So I will zoom in on this a little bit. So this is a manifold, this is mine. So the contrast is green, it's not normally green, but that's just so when you practice, you can tell the difference between if you accidentally injected contrast when you weren't supposed to. But if you see, it has a body, several different knobs. It connects to the catheter here, which would be going in the patient's body. And then there is a transducer that transduces that mechanical pressure into the electrical signal that you see on the screen. Then you have a control syringe. So this is where you're injecting and aspirating and pulling back. Now, our primary concern with injections is air embolism, accidentally injecting air, because this is outside of the body. So if I have a crack or a loose connection, air can enter, and then when I inject, it'll go in the body, and that can be very dangerous. We don't want that. So you really have to know what you're doing, learn the manifold like the back of your hand, know how to do proper injections. If you see air, how to troubleshoot it without accidentally injecting it into the body. So those are very, very important skills to learn and practice. Now, the Acist is an alternative. It's becoming very popular because of the room for error that Manifold has. It is based on the person's experience of using it safely and effectively. So the Acist is a mechanical version. It's a mechanical device, or a power injector is what some people know it as. The rate and volume can be preset. So I can say when we do a left coronary case, I want this much volume at this much speed. I want it to take 0.5 seconds to inject. You can preset those types of things. The rate can also be controlled by how fast you push this button, like the accelerator on the pedal of a car. The harder and faster you push it, the harder and faster it will inject. It does have a transducer to transduce pressure as well. And again, it does, I know you can't see all of it, but it does directly connect to the catheter. And this has some mechanisms in place where it can detect air and it will not inject if there is air present in any of the device. Now, when you are working in the cath lab for the first time, it can feel very overwhelming. Just like when you learn to drive for the first time. I know that was probably a long time ago for a lot of people, but if you can remember at all, it was very overwhelming. You're trying to just stay between the lines, but you also have to pay attention to pedestrians, the cars behind you, to the right and left of you. And then when you're trying to merge on the highway, you're paying attention to a billion things, and it feels very overwhelming. But now when you're driving, you are paying attention to it, but it's just part of your natural process, right? You can see 2 or 3 things at once, even though you're actively staying between the lines. And working in the lab is very similar. When you first walk in, there is a lot to look at, and you don't know what to pay attention to first and foremost. And then as you become more skilled and comfortable with what you're doing in a single task, you can add on other things in the background into your peripheral vision. So for instance, you need to pay attention to the pressure. Is it damped or ventricularized before I inject? The vitals, are there any PVCs, ST elevation, or bradycardia before I inject? As we are doing the procedure, are there any changes with the patient? The pictures, we're looking for anything abnormal, expected, and unexpected. And the pictures that you're actively taking, or a picture you just took if you're reviewing them. The patient, they're only under conscious sedation, so they can see and hear you. They can respond to your commands, so you can check in on them and how they're feeling. There's multiple people in a room, and everybody has different roles, right? So the monitor person who is not actively scrubbed in, they might just be documenting, but their number one thing is to pay attention to the vitals, because that's the monitor. They're looking at the monitor. Everybody in the room should be looking at the vitals, but you might be, let's say, preparing a device and paying attention to the device going into the coronary artery, and you're not fully paying attention to this vital screen, but the person in the monitoring room should only be paying attention to that monitoring screen. So while you're doing this, you know someone else is paying attention to that. So depending on what role you are in and how your hospital functions, it's important for you to ask, at the end of the day, what is the number one most important thing I need to be paying attention to? And yes, eventually you're going to be paying attention to everything, but there are certain moments where you have one thing that is specifically your role, and it's important for you to know and understand that. As a monitor person, if no one ever told you that, you would assume the people in the room are paying attention to the vitals, but there might be certain points in time where you're the only one looking at that screen. So if you see something abnormal, you need to say something. Don't assume that somebody else saw it. And this is why teamwork matters. One person cannot see everything, including the physician. They're paying attention to what they're trying to do. There's so many other things going on, and they're hoping and trusting that someone speaks up if something abnormal goes on. So get comfortable speaking up respectfully and without causing panic, because remember, the patient is awake and they can hear you. So choose your words wisely. Learn what works for the team to call attention to something. And know early signs of issues. Most, if not all, complications are preventable, especially if you can catch it early. Thank you so much. I know that was a lot of information, but please like this video if it was helpful, and subscribe if you want more like this. And we will continue to kind of go through these basics. Enter any and all suggestions that you have in the comments. I know I cannot always get to everything right away, but when I have my planning days, I do go through and just check everyone's comments to make sure that these are the types of videos that I'm creating for you based on where you are. And if you have any future goals, if you're trying to get a job in the cath lab, or you're in the lab and overwhelmed, or wanting to take your RCIS, please comment below or directly email me or message me on any of my social channels, and I will be more than happy